quite a week. Thank you very much for all of your support. Yeah, everything fell apart. Does anyone have a charger like this? I meant to plug this in the car, so I brought this car. This is a phone charger that goes in the laptop? No, it's a USB-C. Like a normal computer charger. Oh, like a normal one? Yeah. This is the thing to plug it in the car, but I don't have a. Oh, yeah. Actually, I think I do have that. Okay. If it's easy. I have my other laptop that is charged, but my D one is not charged.
Can you guys hear me? Still good? Good.
So I spoke to Matthew and Andrew a couple of times.
Good.
I think we're probably all squared away with all the numbers.
Do they give more preliminary data?
They did. It seemed like there's really no major change before and after.
Okay.
Which is
Per enrollee. Yeah.
Which is a little interesting. Yeah. So
I think the information was not strong, so I'm not surprised actually. Yeah, it's really hard for these things to happen. But yeah, congratulations, Abraham.
thanks. Yeah.
How you doing?
Good. Are
Have
you
been
sleeping?
at all? Yeah.
Yeah.
It's like 2 weeks.
It's 2 weeks today.
Yeah.
He's like 2 weeks.
So did you take off 2 weeks? How long did you get off?
Life was just
Yeah, that is one way to put it.
priorities are upside down.
Changed.
Barry, I always wondered if your team's background was like your home, like that you would have some urban place to live and conquer. Do you know what I'm talking about, your team's background? And then I was recently out with someone else with the same team's background, and I was like, oh, it's not his house. Unless they live together. Yeah.
I'm very happy with the place I'm staying.
That's great.
That was my number one.
Do you have a temporary type place or more permanent?
It's an apartment, so it's really close to work.
Yeah.
I usually walk here.
Yeah, so you'll stay there.
Yes.
Yeah, that's great. Oh, it looks like Ann canceled though. Saw that. I don't think so.
Because I saw it with the email. I said, oh, wait a minute. So
Oh, no, yeah, that's someone had raised a question about that in the last meeting. They're right, I'm gonna follow up with them directly. And I think they're usually on Tracy or others, and then we should change something.
Did we end up getting July minutes?
No, I'm sorry, they're delayed.
I will stop looking for them. Thank you.
Thanks, Dee. We are just getting gathered here in the room. A few folks are making their way up from the lobby, so thanks for everyone's patience.
Let's say.
Hi, how are you?
Are we waiting for anybody else?
I think we're just gathering whether we have a quorum,
Okay,
then establishes that, she'll let you know.
great.
This is Doris Lotz. I'm your 4990 number. I couldn't get onto Teams this morning, so I just called in.
Thank you, Doris.
Thank you.
I have 12 right now. I haven't gotten through.
Well, great, that's a quorum.
All right,
13.
great. All right. Good morning, everyone.
Good morning.
Good morning.
Good morning.
Good morning. Good morning.
All right, let's open today's meeting of the Medicaid Advisory Committee. I don't think we have introductions or anything this morning, right? Excellent. One quick item on the consent agenda. This is a rule on the protected income level. As I recall, it's a re-adopt with like no substantive changes.
I believe that's right, yep, it was an expiring rule.
Okay. And how do we do it? We just ask for a motion to approve the consent agenda?
We actually don't need a motion,
Okay.
what we could just do is open it up if anyone would like to make a motion to remove it from consent agenda.
Ah, thank you. Okay. So as Olivia said, we can open that up for discussion if anybody wants to take it off of the consent agenda. Hearing none, we shall move along. All right. So everybody should have gotten and reviewed the July minutes.
We actually are still working on the July minutes, so
Oh,
we'll have
well
to
then,
pick those up next time.
so in my mind, I'm like, did I see that? So, okay. We will postpone that then. We are maintaining the future agenda item on direct support worker workforce.
Yeah, we're keeping that on there because I think we might, and we anticipate having some more information to share on this in the months ahead, so I just wanted to keep it on here.
Sure, sounds good. All right. All right, moving right along. Kelly, membership. We have a new member representing the Dental Society.
Well, yes, we do indeed. Hi, Brian. I see you on screen there.
Hi there, I'm Brian. It's nice to meet and see everybody. I've never really done this before, so I'm happy to be a part of it. And if I can help in any way, please let me know.
Great. So the subcommittee is making the recommendation to accept Dr. Cicero to the membership panel.
Does that need a second? This is Doris.
Yes?
Motion. Oh, yeah.
So I think we have to move to accept the recommendation of the membership committee.
And then it goes to
Yeah.
the vote for the full vote for the group.
So can we get, well, if there is no discussion first, does anybody want to discuss the recommendation of the membership committee? Hearing none, can we have a motion to accept the recommendation of the membership committee?
This is Lisa DiMartino. I move to accept the recommendation from the membership committee.
Thank you, Lisa. Do we have a second?
Second,
Yes,
this is Holly
Doris.
Stevens.
I prematurely did.
Is that Doris?
Yeah.
Okay.
And Holly
Yeah,
too.
second, third, and fourth. I think we're good.
And Holly. Well, and Holly.
All in favor? Aye.
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 Any opposed? All right, thank you and welcome, Dr. Cicero.
Thank you
We
very
appreciate
much.
you being here.
Yay, I'm glad to be here.
All right, Olivia, do you want to talk about the MAC and the BAC transition?
Holly has a question.
Oh, yeah.
Hand up. Holly?
Yeah, I had just had a question because I thought with future agenda items, that was also to open it up to see if there was anybody who had any agenda items that they wanted to add to future meetings. Is that correct? Or has
Sure.
that changed?
No, go for it.
With the changes that we're going to see coming with premiums, co-pays and the work requirement, I was just wondering if maybe we could keep those as standing agenda items, so that if the department has any new information that they know of, that they could bring it forward when it comes. Since it's going to affect a lot of people. Also to the new READY requirements as well. Those three things I think are going to impact our folks a lot. And when I say our folks, I mean, the people that are currently that are beneficiaries that are a part of this committee, as well as any providers, as well as any advocates.
Yeah, Holly, thank you. We had a robust conversation about this last month. This is on the agenda today, and I suspect it will remain an agenda item.
Yeah, we
That's
have on the agenda now, like sort of consolidated federal and state legislative updates.
Okay, so that's what that means. I wasn't 100% sure what that meant. But if that's what that means, then cool. And I hope that it just stays on the agenda.
Yeah, and it's great to raise the topics of specific interest, like you just did. So we'll keep this on the agenda for sure, but then keep the feedback coming if there's specific focus areas you'd like that to include.
Okay, thank you so much. I appreciate it.
Thank you.
Marissa? Bert?
Hi, we talked about this last month as well, and it may be included in the agenda, but with the frequency of these meetings changing, I'm wondering if we can hear from the department how often we're going to be getting the DD unit information and some of that typical data that we might normally see within this committee.
That's a great point. We are going to talk a bit about schedule in the next agenda item, and I think this is a great question of, as we're moving to a quarterly cadence, is there anything we want to receive more than quarterly? Mm-hmm. So Marissa, are you suggesting it would be helpful to get a more than quarterly update, even if the meetings are quarterly?
Absolutely.
Okay, I think we can ask others too about areas where we'd like that, and we can collect that and kind of confirm on our side that the department can continue to support that. I just want to confer with some other colleagues who produced that reporting, but that makes a lot of sense, and thank you for raising. Is there, I guess while we're on the topic, is there anything else that folks have on their mind as information you're worried about getting frequently enough as we go into a quarterly meeting cadence? Don, I see your hand is raised.
Well, I guess I would just ask that the presentation that David and or Henry have been doing around Medicaid, I think would be helpful to have if it's on a monthly basis as well, especially if it's already being run internally, to share that out so we can see trends before we get to 3 months out.
Yeah, we can keep doing we can send out the slide deck of the monthly enrollment figures.
That would be great. Thank you.
We have all those dashboards maintained.
I mean, conversely, I guess I would just say at one point there was, and I apologize if I've missed this, at one point there was I think a dashboard that was going to be public facing discussed, is that would be another way to go about it, I guess, where we could check at any time. If it's already posted and I've missed that, then I apologize.
Yeah, we were maintaining some dashboards during like the public health emergency that I think maybe aren't maintained any longer now that we're.
I know we post the slides from the monthly update slides, but I don't think there's like a real-time dashboard that's available public facing. The internal one isn't real time either.
Well, the slides actually would be, if they're posted monthly, that would be
Yeah,
sufficient
they
then.
get posted
That's
to
great.
the Medicaid website, but we can also just email them out to the MAC group as well.
Okay,
So you don't have
Thank
to
you.
go hunting for them. Yeah.
great. I also have one other agenda item since I'm already off mute.
Please.
I mean, I mentioned it here because I don't think it's been discussed and I don't think it's not on the agenda, but I don't know if it falls under as a question or an agenda item for a future meeting. But I guess I saw last week that SNAP 500,000 Granite State or SNAP information was shared with the feds for immigration purposes. I'd like to know if the department could detail any more information about that in terms of Medicaid as well, Medicaid beneficiaries as well, or if that was just limited to SNAP. I just put that out there for now or later, but get it out there out front.
I think we'll probably want to take that one back to confirm as well with some colleagues. I know the request was focused on SNAP, but I just don't want to speak incorrectly to whether there was any Medicaid overlay. So we'll provide that in a follow-up, Dawn.
Thanks.
Any other topics, questions? Okay. So did you want me to just move into back and back transition?
Let's do it.
Okay, great. And also just quickly, thank you, Dr. Brian Cicero, for joining us. I just want to acknowledge we're excited to have you participating in this forum and have our dental society representation reinstated. So we've been talking over the last few meetings about our transition to MAC and BAC. Just to quickly recap from our last meeting, we approved our new bylaws for the new MAC forum, which is a great next step, and we confirmed terms for current members. So now we are officially moving into our quarterly series. I want to show a mock schedule to get the group's feedback and talk a little bit about what we need to accomplish in our next meeting. So let me just quickly, I just actually realized I'm not on the meeting screen share, so let's do that very quickly. Okay. Can folks see the slide? Yes, looks like it. So part of what we've agreed on in the bylaws from the last meeting is our goal is to meet quarterly and to have the BAC meet before the MAC. And it was suggested to kind of shoot for a cadence where the first month of the quarter, the BAC convenes, and then the last month of the quarter, the MAC convenes. And so we're kind of straddling that a little bit as we're getting into it here. And what I've put on the screen in that table is a proposed schedule for moving through the next year. This Q3 is going to be a little bit tighter together. And I put a red arrow next to the October meeting because I think we could either meet next in Q4 or keep this October meeting. And that's part of what I want feedback on from the group. This first BAC meeting, I think, is largely going to be introductory and orientation as the Beneficiary Advisory Committee meets and proposes content for the Medicaid Advisory Committee to take up. It'll be more of like a direct flow. So that was one question to pose, is preferences on meeting in October versus waiting until Q4. And then in general, I would propose keeping our usual meeting time, which has been Mondays at 10 a.m. on the second Monday of the month. But just keeping it in the last month of the quarter, so that's December and then March, and then you can see, for the rest of the year. So let me just pause only on schedule. Does anyone have feedback on keeping this kind of time of the week as our meeting time, going to quarterly, whether to have the October meeting or not? Just opening the floor for feedback.
This time of day works really well for me.
Great. Yeah, I mean,
So
I think this has been the time of this meeting forever. So anybody who's been involved has just been accustomed. I feel like I'm not aware of any great reason to shift.
Okay, great. Doris, I see your hand's raised.
Yeah, I just wanted to also clarify, I believe it's this time, but also you mean by that Monday mornings, 2-hour blocks, 10 to 12, right? Everything
Yes.
same. Got it.
Yeah, just because we're moving the schedule in general, like, I just wanted to be super clear that that's what we're proposing to do, and make sure if anyone had feedback on that, we had a chance to talk about it.
So we're going to keep it Mondays.
Yeah, so instead of monthly Mondays, it'll become, in the case of Medicaid Advisory Committee, the second Monday of the month, 10 a.m., October, and then December, March, June, September, December. And if we're all good with this, I will send out a new calendar series like you have today with like an Outlook calendar invite with those actual dates so that it's on everyone's calendar.
Make sure you delete the current one.
You don't have to, because it ends after
Today.
Oh,
yeah.
perfect.
This was the last one and then what?
And how long are the terms?
The terms we shared in the last meeting is based on folks' feedback. I don't remember yours off the top of my head, Kathy, but we can send that to you just to reconfirm that you are good with what we have your term length down for.
Okay, because I mean, you guys should be getting sick of me by now.
We'll never be sick of you. Unfortunately for you, I don't think we're ever leaving you alone. So thanks for raising. But yeah, we'll send you your term again just to make sure it's looking right from your perspective and preferences.
All right.
Anyone else? Any feedback on cadence? Okay, so I'm going to move into then.
Oh, just from the chat,
Yeah.
Christine Dyer said, please keep it to the same day and time.
Yep.
Frame in an October meeting sounds great. And then Kelly Cappuccino said she supports the proposal.
Awesome. All right, thank you so much for your feedback on that. I did want to highlight, so then if we are meeting in October, we need to vote on the chair and vice chair for MAC. So what will happen out of today is anyone who has nominations for chair and vice chair of the MAC should send them to either Kristen Vinifrock, or you can send them to Kristen, and Kristen's going to share those nominations with the membership subcommittee. And so as we kind of normally do it, the membership subcommittee will meet, we'll look at those nominations. If there are recommendations that the subcommittee wants to make, they're welcome to do so. And then in that October meeting, we'll hear any recommendations from the subcommittee, and then all of the nominees, and we will vote on chair and vice chair for the MAC. So please send in, you can nominate yourself, you can nominate somebody else. We welcome nominations for our next meeting. And then I just also, Doris, go ahead, sorry.
I like the raised hand feature, but it doesn't mean that I have to talk right away. Just putting myself in the queue. I missed the July meeting, so and as we said, minutes aren't quite ready yet. So, is there any prohibition to nominating the current chair and vice chair? I mean, everything kind of resets with with this new agenda and new bylaws? Okay, thank you.
There is not, yeah. So the current chair and vice chair are on the table for nomination. I also wanted to highlight that another new feature from our bylaws is that there is now going to be an MCO participant in the MAC. So in that October meeting, we'll have prepared who that is proposed to be to get them added to the MAC. And then Marissa, go ahead.
Oh, you're on mute.
Sorry about that. I never thought that I would say this, but I just thinking about the fact that so many of us already have this date and time in our calendar for what was MCAC. Is there any interest or possibility that we could continue to have updates from the department during this time period, even though it wouldn't be a technically an MAC meeting? Is this a good opportunity to use the fact that we have this group already with this time in their calendar for updates? Like I'm very concerned about all of these changes to Medicaid and then going to a quarterly meeting. And I understand why it has to be done.
Yeah.
But do we want to use this time to continue to get certain updates from the department on the health of Medicaid in the state?
Yeah, this is a great question. It did come up a bit when we were talking about going to quarterly. So let me know if this kind of responds to your interest. But we definitely feel like there could be what we might call off-cycle meetings, right? Just because there's time-sensitive topics that the MAC would like the department to present on, and that's true for the BAC too. So I think in both cases, what we have in our bylaws and what we're approaching is it's a quarterly scheduled meeting, but the members are welcome to request, like we can work on what we call an off-cycle or sort of special meeting for time-limited topics that we feel we need to respond to sooner. So I think what we could do, Marissa, is, you know, if the committee wants to recommend that for certain topics, I think we should handle that as it comes rather than plan on a monthly forum, since that would essentially be the department like preparing an agenda monthly again. Does that make sense, or does that feel like it meets the needs of what you're phrasing?
It does, and I guess I would want to hear more about what's pictured when you think about how does a member make a request? Does it have to happen at the meeting before? Do we, could we just send somebody an email and say, hey, I'd really like to hear from the department on this topic? Again, I think about all of the things right now with Medicaid, all the things we don't know what we don't know as a system. And I want to make sure that, I think about the timing of this. Maybe if it were 2 years ago, a year ago, it would be a little bit different. But right now, I'm just very, very concerned that we're not going to get the information about Medicaid that we can pass down to the people out in the world that we all support.
I think it's a good idea to have it on the agenda items agenda, right? So like every time we're talking about future agenda items, there's also that opportunity to propose like an additional meeting, right? So that if there is an agenda item that you're saying, I don't want to wait for the next quarterly meeting, I think this should be addressed before then, it would give us that forum to decide as a group that that's something that needs to get scheduled. I don't want to preclude like reaching out via email either. I think that's, we're also open to that, but that might be just a good way to keep it as an option. So I guess based on how you're thinking about things today, do you feel like October as our next meeting, are there topics that you are hoping to hear about before October for specific presentation?
I mean, it depends on what we hear today. It's hard for me to say. I really am just thinking about the rollout of all these changes, the timelines for all these changes, how state changes will intersect with federal changes, analyses of the impact. It's an information like what's being looked at, who is being impacted. So it depends on what is in the rest of the meeting. And I don't want to take up too much time. So if there's anybody else that wants to add.
Yeah, You're not taking up too much time. I think it's a really important consideration because you're right, there's a lot going on. And I'm just trying to balance, like, I think we can always add to our list of what we're providing on a monthly basis as like reporting, you know what I mean? Like the DDU updates we just talked about and the enrollment updates. And then also making sure that if there are sort of discussion topics that we need to have before the next quarter, that we're addressing that. I'm just a little bit cautious about a standing monthly because from the department's standpoint, that would mean we really like to prepare something based on a specific request. It just helps us be efficient with the information we're putting together, how we're using your time. But I think it's a balance that we should keep an eye on as we go forward here. I will say I don't think we're going to have a complete timeline by September, so I don't think we'll be missing out on some polished product then. But again, I hear you. There's a lot to track, so I appreciate you raising this.
So my hand's up.
Kelly.
Go ahead, Kelly.
Thanks. I'm sorry to interject this thought because it doesn't completely stay in alignment, Olivia, with what you're saying, but it doesn't completely contradict it either. But I do share the same concern that's being voiced in terms of this transition period. I understand the monthly meeting and having standing meetings just for the sake of having it. But is it reasonable for us to create a subcommittee, even if it's of a group of people who want to get the monthly data that you're going to send out, and then we can convene to look at it and identify any questions, even if they're for immediate or for the next meeting when we have an MAC?
I mean, subcommittees definitely can, I think, come together on any cadence that the subcommittee wishes to. So that would be totally, that's not out of alignment at all from my perspective. And I think just going back to this point of collecting what information on a monthly basis is requested will be helpful. So again, we're hearing the enrollment updates and the GDU updates, and then as we go along, just keep that in your mind of what else would be helpful. Go ahead, Henry.
So I think today part of our presentation is to walk through a link that we gave you, which was the Kaiser Family Foundation. I think at different points in time, timing may matter, but in terms of the frequency, I think in terms of what's changed with HB2 and other legislation is statewide, and then what also is changing federally and the time thereof. So I think having some flexibility on this based on kind of the timing of things and when we actually will have updates, because there's a lot of work that has to be done to address some of the items. Some of them, there's a specific date and a specific thing that you'll be able to walk away today with that you'll know. Then there's sort of the impact of that, which we'll have to track and monitor, because best laid plans on impact is really, that's going to play out. So I'd say a mix of what's going to happen. I think let's bring this up for discussion at the beginning of next meeting after you have a chance to absorb what we talked about today.
Sense. Okay. Anything else? Is there something in the chat?
Yeah, there's Cheryl Steinberg said, regarding information sharing, is there any update on the dashboard DHHS is required to create for the system of care for healthy aging?
I don't know the latest on that, but I'd be happy to take it back.
There may be something.
Yeah, I know Wendy's not able to be on today. Yeah, unless Christina, you have an update. Okay, we'll definitely take this back to our LTSS colleagues. Thank you for raising. Anything else in the chat?
No, that was it.
Okay. Well, this has been a very smooth segue to the next agenda item. So thank you very much for the feedback on the transition items here. And as always, just in general for the feedback and engagement as we make all these changes. It's really appreciated. So I think next we're gonna move into anything we're sharing on federal and state updates.
So we returned around.
Yeah, let's
We have here early.
we're moving ahead of schedule. Oh yeah, we are actually 30 minutes ahead. David, maybe you could do enrollment.
Oh, the enrollment, yeah. So-
Yeah, I'll do the enrollment. Just a second.
Is that okay with you, Brett?
Sure. So this is the monthly enrollment update for the month ending in July. And this is the first full month in which we're seeing the change that was part of HB2 of returning to normal redetermination eligibility processing, so the removal of the E14 authorities, which increased the passive renewal rate. So you can see here the total at the start of August 1st was 180,000. We prior to this, we've been running around 184,000, 185,000. And so in this past month, there's been around 5,600 people have lost coverage. There was also 3,800 that gained coverage, so the net decrease was around 1,800. That net decrease of 1,800 was predominantly Granted Advantage and kids. And within the Granted Advantage population, the majority of those who lost coverage had been enrolled in Granted Advantage for 6 or more months, which I think is what reflective of what we've seen in the passive rate of a really high passive rate, where people are renewing passively in the terms of 80% or so, which is now around 30%. So this slide shows in the change in the prior 12 months by eligibility group. And so in the adult category, this brown line that looks like a roller coaster is the Granted Advantage population. And so the increase here is the open enrollment on the exchange, which typically will see increased Medicaid enrollment then, because if someone applies for exchange coverage and it looks like they're Medicaid eligible, the exchange transfers the account to Medicaid for a Medicaid determination. And then typically we see that trail off as the year goes on. But there's a steeper decline this year due to the change in the E14s, which went into effect for July 1. So the net result is a decrease of 1,700 over the prior year. And down here you can see the children's, the changes in children's group. So the low income non-chip kids is the purple line here. And you can see that decrease from the prior month. And this is a similar look, but it goes back a little further. So it goes back to November of 2023, which was what the low point was after we started the unwind. And at that point in time, we had 178,000, so we're still a little above that. We're at 180 total. And it just shows the change on the first of the month on a monthly basis. This is a similar look, but it's broken down by MCO, and we also included dental. So it's the start of the month. So you can see the dental enrollment, which has been around for the past year, was 89,000, now it's 87. And that's just for adult dental. So this is the redetermination dashboard for the total population for July. So there were 10,720 individuals up for redetermination. 3,752 closed. 6,530 completed their redetermination. Of the closures, 2,476 failed to read, which means they didn't submit their renewal form. And we had been seeing, the failed to read is always sort of the number one closure reason. It's larger this month due to the change in the ex parte processing. This is the same look, but for children. So there were 3,887 children up for redetermination, 932 closures, 2,739 completed the redetermination. Of the closures, 725 were for failure to provide the renewal form.
Do you know how many of those kid cases are connected to an adult case versus child-only cases?
I can't tell you off the top of my head, but I think we could probably, I connected with Andrew, but we should be able to rank it up because we have the household data.
Yeah, I'm just curious, like, if there's a higher incidence of failure to read on a child-only case versus a case that has, you know, parents who are somewhere.
Also.
Yeah.
Yeah. Yep. Yeah, I think the unique thing with kids too is they have coverage up to 323% of that PL, whereas the adults it's 138. So there is a large group of kids that they're going to be the only Medicaid individual within the household. Yeah.
Bears repeating what we're doing. All of those.
Oh, yep, and we have some slides on it too. But Vern, if you're on, do you mind just reminding everybody about the communication campaign that's going on and how it changed recently with what you're doing with the MCOs?
Oh, sure. Did you want to go to those slides, or do you want me just to talk about it briefly? So what we did is we had a transition month. This month we made calls for two separate categories. This first slide shows what we did, what the MCOs did for their outbound calls on the closures for June. So these individuals had already closed in June. This is the campaign that we've been doing for well over the last 6 months. There were 889 individuals that needed to be reached, and messages were left for about 51% of the individuals. 229 were actually reached, about 26%. Of that, the ones that we reached, 26% had already completed their redeterminations. Those that were aware and actively engaged in doing their redetermination was 37%. New insurance was 14%, about 31 individuals. We did see an increase in the number of warm transfers to the New Hampshire Navigators. So this is individuals who may have not done a redetermination because they didn't feel that they were qualified, and so the callers from the MCO will actually stay on the line with the individual and get them over to the Navigators so that they can talk about insurance coverage. I would have you go ahead and switch to the next slide, please. I see Dawn's got her hand up. Did you have a question on that slide or just in general? Oh, okay. Just want to make sure. So this next slide, this is a new campaign that we have started, and because we know that the E14s have expired, what we want to do is outreach to individuals before they close, because there are more people that need to complete that redetermination now that may not have had to do it in the past. For this, we actually pulled 4,277 individuals who were set to close at the end of July. And of those, 2,194 were adults, the rest were children. Messages were left for 2,272 individuals, but the MCOs were able to reach 1,123, about 26%. Of those that they were able to engage, 38% had completed their redeterminations and reopened. 3% of those who had done their redeterminations no longer qualified. There were 568, which is about 53%, that were aware that they needed to do their redetermination, and they were working on it. So these were individuals that had not closed yet, but they knew that they had to get this redetermination done. Um, 11 individuals that they reached had actually indicated that they already had new insurance. They were able to get 5 people over to the navigators so that they could talk about what options they might have for insurance. They didn't think they qualified for Medicaid anymore. We did have one group, one of the MCOs that had a large number of DCYF children, and so we'll be following up on those separately. But as you can see, whether we seem to be calling near the end of the month for people who have already closed, or we're calling for individuals who were about to close. In July, it was pretty close. About 26% of those that were attempted were reached. If we could go to the next slide. So Medicaid medical unit, they also transitioned this month, making calls to those that were going to be closing. Instead of the individuals who had already closed. 86 individuals called, 74 were reached. Little different from the MCOs. They actually, the Medicaid unit reached 81% of the individuals that they were trying to. 60 have completed their redetermination and they are now open. 4 were no longer eligible for Medicaid. 7 were aware that they needed to complete the information. Of those that we reached, no one had new insurance, and no one had moved out of state. And I think one of the things that we're finding is that we seem to be having good luck with the individuals that we reach, that they're willing to talk with us and tell us what their status is. Let's see. Sorry, I'm seeing little things at the top. Kelly, did you have a question? I think Dawn said you were all set because your hand is still up.
I have a question for David,
Okay.
actually. So you finish what
okay.
you're covering, that's fine.
I do. I just want to ask, and I did put it in the chat, but I meant because we have Dr. Cicero with us and we're flying through this data and I can see him looking at it, probably likes it as much as I do. But can you just remind him about the E14 authority so he knows why we're even talking about this?
I
Yeah,
do
no, that's a
appreciate you
great-
thinking of that.
Great point. So, Brian, the E14 authorities were authorities from CMS that all states were allowed to use during the unwinding, and it helped states streamline eligibility processes and allowed states to rely more heavily on external income data. And so the 2 authorities New Hampshire relied on were, there was one where if the person, when they applied for Medicaid, had 0 income, and we checked all external data sources and found no information, we could assume that there had been no change in that person's income. They still had 0 income, and they would get passively renewed without having to verify that they still have 0 income. And the other one was a similar one, but the threshold was 100% of the FPL. So if they were at or below 100% of the federal poverty limit, we could do the same thing. As long as we've checked the external data sources, we could rely on that old income data. And in some cases, we're talking about income data from the start of the public health emergency. So, May, June, July of 2020. And, things have obviously changed since then. And so in the return to normal eligibility processing, we're no longer relying on that old income data, but asking for more updated income verification when we don't get any income data from external data sources.
Okay, I see now. Thank you.
Yep. Dawn, did you have a question?
Sure. Going back to, hey, perfect. Going back to David's slides, the first slide, it seemed like the group that had the largest change in eligibility was adults with disabilities, which is concerning to me because most people who have disabilities, those are long-term. So it's not the kind of thing that they lost their disability. So I was wondering if, which kind of leads to my next I have a multi-part question, I should say. So I guess also when you look at that 1 month data, I think it was the first slide that you had, David, that showed like from the beginning of the month to the end of the month, I think a lot, like it seems like because some people, I don't remember the exact numbers that you used, but it seemed like almost as many people gained coverage as lost coverage, which makes me wonder how many of those are new beneficiaries and not folks that churned off and got back on. And so I was just wondering if you have any analysis of like unique new beneficiaries versus people who've churned off and on. And then I guess I'll stop there, and then but I do have a second part.
Sure, so I think you were talking about this slide, and so the roller coaster one here, this brown one, this is granted advantage, not adults with disabilities. Adults with disabilities is this gray one.
Yeah, the first slide, if you go back again, that number of adults with disabilities was the largest drop from 16 to 14,000, I think.
Yep. Yeah, so this one right here, there was 16,000 at the start of the public health emergency, and then there's 14,000 enrolled. I think this is, we've discussed this previously, and we have, slides and other month decks. But if you look at the long-term trend of adults with disabilities in New Hampshire, it's actually decreased pretty, it's pretty linear for the past 10 to 12 years. And it really lines up with when New Hampshire expanded Medicaid. And so I think what's happening is a lot of adults with disabilities are getting coverage through granted advantage before going into the disability eligibility category.
Okay.
Yeah, we can bring back that slide next month too. But it's a similar thing when you look at, kids too. You've seen, if you look at just like the number of school-age kids in New Hampshire is also decreasing because there are less kids in New Hampshire than previously, and so that also you see similar trends in Medicaid enrollment.
Okay. Well, I think we see the turn up in the DDU stats too, right? Where they'll say this many people have been waiting this many days, but of them, X% are covered on a different Medicaid program, and it's at least with the adults, it's often granted advantage while they're pending APT.
Right. This is an ongoing issue that you'll hear me bring up periodically because people, yes, they're covered by granted advantage, but there are still additional benefits for someone who actually has that disability determination. For example, like the APTD cash assistance. So I guess I just, I continue to be concerned that there's some kind of like inconsistency there or something, but or this trend not trending in the right way, but that's okay. I just wanted to also mention the failed to ready category, and I think I've mentioned this before, but it's such a huge portion of the different buckets, if you will, that you categorize when people fail to ready. Like failed to ready is like the overwhelming number. I feel like there must be some other breakdown beneath that, which is what the MCOs are getting when they do the outreach. And it's great that they're doing that new outreach campaign to folks before they lose coverage. I think that's awesome. If there's a way to kind of break that failed to ready bucket down even further, I think that would be really helpful, because again, I think that would get to churn. It seems like people are coming off and going back on, but I know I'm also like a broken record when it comes to churn. So, and the last thing I guess I would say, because of that outreach, we know that at least the MCO data they just shared, like 3% of those people that they reached were ineligible. That means the rest are just still in the process, and they're essentially churning off and then having to get back on. And then did you, David, and I apologize for the mini part question, but did you mention the last month you said the ex parte rate went from the 70-something% to the 20-something%. This month, what was it this month? If you said that, oh, is that next? Never mind.
Yeah, so this is the ex parte slide. So you can see, we were in the low 80s to mid 70s for much of the last year, and then July It dropped to 25%, and that was the first month in which the E14 authorities were moved, and then for August, it was 29%.
E14 authorities was not an optional.
Yeah.
Right.
Either from state or federal.
Right, okay, thank you.
Kathy?
You guys are probably not gonna like this question, but I'm gonna ask it anyway. Do you ever keep track of like a Medicaid error, like when you guys make a mistake? Because you do make mistakes. I mean, I was off Medicaid for a week this summer because you never got my paperwork and I was there when Carolyn turned it in. And, you know, so I know you make mistakes because you've done it before and you keep track of those. Like when you say people fail to be determined, most people that are in my situation who need assistance with like personal care, they don't. I mean, that's the only way they can get that kind of help is if they have Medicaid. So, you know, if you keep track of your mistakes, because they do happen.
Kathy, is your question if the department tracks their error rate in Medicaid?
Yeah, yes, that's exactly my question. I'm sorry I didn't ask it right.
It's a lot more complicated than that, but I think that I will share that one of our major initiatives, roadmap, which I think we previewed when we went over roadmap, is long-term care eligibility, making it easier. Where it's a roadmap priority in the coming year, which and we've already started working on it. In addition, we're engaging UNH to work with the eligibility team on further refining our policies and procedures so that they can be more easily followed and be consistent. And then we're also got this training scheduled all before the end of the calendar year. So there are all sorts of nuances as to why sometimes people don't open up, and sometimes it's a function of not understanding a notice. Sometimes it's a function of many things, I guess I would say, that where it comes through. And I think also too, just keep in mind, it's not been that long since we've transitioned from 3+ years of not having.
I want to know if you keep
I know you're.
mistakes.
I know that you might want to call it a mistake, but I'm just saying sometimes it's a lot more nuanced than that in terms of whether it's a mistake or not. Like someone may provide a document and they, like for example, a trust may be missing a key page that they didn't supply. So they provide the document. They weren't necessarily aware that they themselves picked up that this particular page wasn't there or something like that. There's a lot of nuances to it. And suffice it to say, we know that we're making great efforts to prioritize making long-term care LTSS eligibility easier. That's what we can report today.
Okay, I didn't really get your answer, but okay.
All right. There's something in the chat. Marissa Berg said, in your data gathering, are you able to differentiate in future charts adults with disabilities to receive ABD, DD, IHS waiver services? You now only specify one of the 4 waivers. CFI.
Yeah, we can drill down into the various the other waiver categories as well, in addition to CFI and nursing facility coverage. This slide, But yeah, so this is just the CFI population here, and then we have the nursing facility, but we can do ABD, IHS as well, the others.
I think we have another hand up.
Isadora?
Hi, this is Isadora from the New Hampshire Council on Developmental Disabilities. I want to go back to Kathy's question because I think it's important and I don't think it was answered. We receive many reports from individuals who submit documentation either in person or via the online systems who are then told that the documents were never received. That is not an individual error, nor is it nuanced. There is some sort
again,
of
I think, sorry to interrupt. There's a lot of nuances there. We went through it and we heard that feedback. We did a detailed analysis of it, and part of it in terms of lost documents. I'm not saying there's never an error, okay? But there's a lot of nuances here. We did a detailed analysis with long-term care facilities in terms of quote lost documents. What we found is that they actually weren't uploaded into nuance. They were sent via email without a specific direct place where it needed to go. We worked through that, and I think we cleaned that issue up. There are lots of issues, and we want to hear about individual cases, and we want to hear about, and when we get those cases, we follow up on them, and we do make changes, and we do correct things that are brought to our attention. But I just don't think we can create a report like what you're talking about because there's so much nuance as to why something doesn't happen. We can correct individual cases. We can look for patterns in those cases, but we can't create a report like you're asking for us to. Sorry.
the answer is no. So that's all you had to say. It was a yes or no question.
Yeah, it was a yes or no question. That's it.
It's a nuanced issue. I think that I'm just trying to explain to you that,
But you
that
don't
these
track
situations
it.
that come
That
up,
is
and
the
I handle a
answer.
lot of them personally, including some of the speakers that have spoken in terms of these issues. We're doing our best. We're making it a priority to make long-term care eligibility easier.
I'm not
That's what I
saying
can
you're
tell
not
you.
doing it. I just want to know if you got track of it. That's it. That's all.
Yeah, thank you.
Thanks.
Thank you, Henry. Marissa?
Hi, so two questions in one. Is there a role that the Bureau of Family Assistance plays in determining eligibility? And if so, could we hear from them at a future meeting about what that looks like?
I think that would fit nicely into our roadmap reporting since we're definitely working in close partnership with them on the Making Eligibility Easier roadmap initiative. So I think that's a great point. That could be a focus of as we report out on the progress on that initiative.
Thank you.
And I know they're not typically on this meeting, but I think for that topic, we could bring some folks on the team.
Was it Holly?
Yeah, I just had a question. I know that you had just mentioned doing a deeper dive on the waiver programs. We know that, from Dawn's comment, there are a lot of individuals who have disabilities, especially mental health disabilities, who are in Granted Advantage, and they're encouraged to stay in Granted Advantage because the match rate is so much higher, and they may not need those extra services. So it makes sense. But does the state know how many of the individuals that are on Granted Advantage actually qualify for another Medicaid program? And if so, is that kept track of? And is there any way that we could find out, with those individuals, how many might be losing coverage, knowing that they possibly, even qualify for one of the other programs? If that makes
Holly,
sense.
I just want to take issue. I don't think the department is encouraging people to stay in Granted Advantage because it's financially advantageous. I think people stay in Granted Advantage because their income is too high. And a lot of folks that you're describing had a work history and their income is too high for APTD. So Granted Advantage is an excellent option. But I know folks
No, a lot of folks who are in Granted Advantage are there because they are not working and they have not yet qualified for disability because the state requires 2 years of not working in order to qualify for the disability Medicaid. So they're not working. And then after that 2 years goes by, they remain in Granted Advantage instead of switching programs. And those are the folks that I'm concerned about.
So I think the chair is correct in saying that we do not tell people to.
I agree, and I take that back, Henry.
And then the second thing is that if a person applies, you have, when you do your Medicaid application, you have to pick what you want for services. It's not really discretionary for us to put someone in a category or not if they haven't applied. So again, I think there's a lot of nuance here in terms of where people end up and why they do. But I can assure you that we're not telling people to stay in Granted Advantage. And I can assure you that if people apply for a benefit, it goes through the system, cascading effect and when someone loses coverage, we also check a cascade to see if they qualify for another eligibility category without them having to ask.
And Henry, I take that back. I
No, it's
shouldn't have
okay.
said
No,
that.
but
And
I want to sort of remember the before times where those folks would have not been eligible at all because their 24 months hadn't passed yet. So like this is an excellent option, and like I just don't want perfect to be the enemy of the good. We have work to do. We know it.
yeah, no, my only question is the other ones are going to have a deep dive and they're going to be reported out on. The folks that for whatever reason remain in Granted Advantage, is there any way to know how many of them would qualify for another program, and can we get information on that? That is my actual question.
If they haven't had a disability determination, how would we know they potentially qualify for another category?
They would have had a disability determination because they end up on Social Security disability.
We'll take that away.
Yeah.
Anything else on eligibility and enrollment before we move on to state and federal changes?
Joan? Or are you not you? I think she's just not.
Okay, if we could just remind folks, if you're not actively asking a question or interacting, if you could mute yourself, that would be great. We're getting some interference from folks. Thank you. Okay. This is a great segue, as Olivia said a minute ago, for the federal and state policy changes.
So Rob, do you want to start us off with any updates on the state front?
I'll just do a few bills that have been signed since the last meeting, and I'll transition to David and Henry for the federal and state interaction, because I know there's a lot of questions about the planning there. So since we last met, a few bills that are of consequence that have been assigned were HB 712, which is limiting breast surgeries for minors. HB 377, which is relative to healthcare professionals administering hormone treatments and puberty blockers. We also had SB 118, which was a bill that did several things, but I'm going to focus on one of the long-term care portion of it, which is relative to the personal needs allowance for residents of nursing homes, which essentially increases the personal needs allowance in accordance with the cost of living with Social Security. And those are the big ones that have been signed since we last met. So with that, I will turn it over to David.
So the federal updates, I can share my screen, but we had included in the agenda a link to this Kaiser KFF article, which summarizes each section healthcare related section of the HR1, the federal legislation. And it has a background of what it is, description, and an implementation date. So the first one here is the work requirement. And there is overlap with state legislation that was passed under HB2, directing the department to submit a waiver to implement a work requirement similar to what the department had done in 2019. And then under the federal law that changed is it's a requirement for all states to implement a work requirement, and there will be a state plan option to do that. And it's for your Medicaid expansion population, so individuals ages 19 to 64. There are exemptions for certain adults, including parents with children under the ages of 13, and those who are medically frail or participating in substance use disorder treatment. And one of the unique aspects of the federal law is that CMS has no legal authority to approve additional exemptions other than what was in the federal legislation. So states cannot add to who can be exempt from the work requirement. And the requirement would be 80 hours a month under the federal law. And it has an implementation date not later than December 31st, 2026. So it's effectively starting January 1, 2027. A condition of eligibility will be meeting the work requirement from yours.
Within the last 90 days.
Yep. Within the 90 days prior to application. Or
at least 1 month,
redetermination.
at least 1 month and then 90 days prior to, if they don't otherwise qualify for an exemption.
Yep.
Right? And so I think what we need to get clarification on is for people who are in the program, does they kick in when they have their redetermination. And, so there's guidance that's due to the states on this that we won't have for a while. So when we're talking about updates on this item, I think the best we can do right now is we have a date of December 31st with 26 to be compliant. We know about the condition of for people who are newly applying that they would have to have met it once in the last 90 days, and or they're exempt. Another dimension of this too, which is I think important for individuals and providers to realize, common with this is the retroactive coverage period which we'll cover later, is narrower, and so when we get to that point, we'll cover it. But it's not just narrower for Granite Advantage, Medicaid expansion for everybody. We'll go through that when we get to that.
Kelly?
Thank you. I was wondering if you have any insight, any more clarity on, with regard to exemptions, on who might qualify or what the process might be for them to qualify. And I'll be fully transparent, because in my field, people think the interpretation is that BBH eligible people qualify. And so even if that's true, which I find it hard to believe that that would be the basis, do you have any insight into when we'll have that kind of
So
lens?
there's believe it or not, the rulemaking from a federal standpoint is not due until June of 26. That's what's in the statute that was passed. We do expect that, since this is one of the higher priorities of the administration, that we'll be getting feedback along the way in some form, but that being scheduled and what form that's going to take, it's not available to us yet.
That's very helpful to know. Thank you very much.
And well, at the National Medicaid Director level, there are going to be work groups working on this, so states can learn from each other. That will be starting this fall, and running for a number of weeks. And then I suspect after that, similar to the unwind, we had regular cadence of meetings with CMS to talk through things so that when they do issue guidance, they do issue regulations, they do so with state input ahead of time.
Dawn?
Me again. Thank you for the information, Henry. I understand the federal timeline for the rules, which obviously put a lot of pressure on the states to implement, turn around quickly to stand something up with 6 months after the rules are issued potentially. I just wanted to talk for 1 second about our state statute that was passed, which I know you are well aware, and you all shared the timeline for that at the last MAC meeting. So I was just wondering if the state, if you all are looking at what was in the federal statute to model the waiver that you'll be putting together for fiscal at the end of this year, or if you're using the waiver, that New Hampshire developed last time. I guess I'm just trying to get a sense of how you're approaching the fact that we have this state directive and the federal in terms of the actual substance of the program that you're trying to stand up in terms of work requirements.
I think that as we understand the federal legislation, that things that are in our law would not be consistent with federal law. So on the positive side, from the beneficiary standpoint, we had 100 hours previously in what's in statute today. The federal requirement is 80. We had exemptions for parent caretakers of children. They went up to age 6, and the federal law goes up to 13. So we're working through those things. I think probably in a 30 to 60 day period, we can give you a clearer sense of it. I think we have to present our plan in November to fiscal. So we got to work through all this, and that's what we're doing right now.
Thank you.
Welcome.
Christine?
Thank you. Can I clarify, are you submitting a waiver as the statute requires or a state plan amendment to fiscal?
So Christine, the CMS has spoken but has not issued anything yet on this. And Dr. Oz, the secretary, the head of CMS, has talked about potentially a state plan amendment. And so I think one of those two tracks is potentially the way that will go. We would need fiscal committee approval, et cetera, to submit whatever we submit.
Okay.
But we haven't seen anything.
Okay. Thanks, Henry.
You're welcome.
I know we're spending a lot of time talking about things that are sort of, I'll say in air quotes, way out on the timeline. Can we zoom in on some of the things that are coming right up, like the co-pays and stuff?
So we're going through the federal stuff now.
Sure.
We can zoom through that as well. But I guess the long and short is federally, nothing happens before the end of 26. That is material. There are some things related to that are important to people who are whether they're qualified aliens or not with respect to access and benefits, but I think it's probably too technical to go through here. But I guess we can sort of run through this fairly quickly. A couple of things.
Yep. The other eligibility change that's on the same timeline as the work requirement is more frequent eligibility determinations, and this is the federal requirement that for people in the Medicaid expansion population, they need to redetermine not every 12 months, but every 6 months. So it'll be redeterminations twice a year for that population. And that's effective on or after December 31st, 2026, so effectively 2027. There are also some requirements, enhanced requirements for states to verify enrollee address and other information. New Hampshire we verify address information, so I don't think that will be a big significant change here. Similarly with ensuring deceased individuals no longer remain enrolled. There were some changes to CMS that published some rules around eligibility to help try and streamline eligibility processing, and the federal legislation changes the effective date of some of those rules and pauses implementation of rules that were not already in effect. This same here, there was a Medicare Savings Program rule that went into effect that the federal legislation pauses. There are some changes around restricting eligibility for qualified aliens that Henry had, or non-qualified aliens, which Henry had just mentioned. That does have a slightly earlier effective date of October 1, 2026. The other change here, which is tied to, it's on the same timeline as the work requirement, the redetermination is twice a year, so January 1, 2027, and it's changes to retroactive coverage. So right now, all Medicaid beneficiaries, regardless of eligibility group, are eligible for up to 90 days of retro coverage, and this changes to only 30 days of retroactive coverage for Medicaid expansion population and 60 days for everybody else. The federal legislation also for the granted advantage population, so Medicaid expansion, included a requirement for cost sharing, and it specifies specific services that are required for cost sharing. There are some services that are exempt, so primary care, mental health, substance use disorder services by FQHCs, behavioral health clinics, rural health clinics are exempt from cost sharing. And what this is on a October 1, 2028 timeline, but it also overlaps with one of the state budget HB2 provisions, which was a requirement to submit a waiver for premiums within the granted advantage population. And so the federal legislation directs states to do cost sharing and not premiums. So we need to have some discussions with CMS around whether or not we could get a waiver of this new cost sharing requirement to do premiums. There are also changes to provider taxes. So in New Hampshire, this is known as the Medicaid enhancement tax, and what the federal legislation did was capped. It has a moratorium on new provider taxes, but the big impact for New Hampshire is that the federal legislation changes the cap of how much a state can, of the provider tax rate. Currently it's capped at 6%. It brings that cap down to 3.5% by 2032. And so New Hampshire's is currently at 5.4%. And so we'll see in 2029, our rate will be decreased from 5.4 to 5%, and then it'll decrease 0.5% a year. So it's 3.5%. There are also changes to state-directed payments, which is a reimbursement methodology Medicaid programs use on how they can direct the MCOs, so the managed care organizations, to pay providers. And the amount of dollars a state can pay out in state-directed payments is now currently based on the average commercial rate. What the federal legislation does is it reduces that amount that states can pay out to an amount that would be equivalent to what Medicare pays. So effectively limiting states from being able to pay any higher than the Medicare rate.
So this is just to put some context on this in terms of what it means for the overall Medicaid program and for beneficiaries and legislators and the like, is that we calculated that the net change of these items together is about $3 billion over the 10-year period of reduction to the state.
$3 billion reduction in federal funds.
It would be state and federal.
Okay, so,
So the not being able to collect a full 5.5% plus the federal match.
Christopher, is there an estimate regarding what the losses will be from the provider tax changes in New Hampshire, or too early to tell?
That's what the number I just gave.
Oh, I'm sorry.
The provider taxes and the directed payment. It's about 3 billion, could be a little bit more than that even.
Sorry, can I just, so is that specific to New Hampshire? Or is
Yes,
that all?
That's New
Wow.
Hampshire, over 10 years. So the impact of those things are not in 25, 26, 27. They probably begin in what would be our state fiscal year 29.
Oh, Lisa?
Did I hear that correctly? The state of New Hampshire is going to lose $3 billion in federal funding, or is that the state and federal combined?
The state and federal combined.
That's
over 10 years.
Over 10 years. Okay.
Starting in, the law went into effect like July 4th, the 10-year period from July 4th. But we don't really see any reductions happening in the early years of this. They're backloaded.
Okay, so we don't see any, okay. And this is the tax that hospitals and the state were using to receive federal money. Am I correct on that?
Yes, the Medicaid enhancement tax, which is the hospital tax, is the one that's set to the reduction. The good news with respect to the tax law, they didn't change long-term care facilities. Nursing facilities have the NFQA tax, facility quality assessment tax. That can remain where it is. So there's no loss related to that one. This is fully focused on hospital.
But it affects the whole Medicaid system.
Yes, it does.
Right? So it's going to have some unintended consequences in a few years affecting, neurodevelopmental disabilities, mental health, the whole system as a whole, right? So I guess.
Those are intended consequences, not unintended.
Yeah, so the Medicaid enhancement tax.
You're right, Lisa. You're right. Intended. Yes.
The Medicaid enhancement tax has always been a portion goes back to the hospitals in the form of federal match that we generate on that, not the tax itself doesn't go back to them.
Okay.
And a portion also has gone to fund all other provider types that are within the managed care program. So all the types of providers there, and so it is a meaningful issue. On the positive side as well, we were able to obtain grandfathering status so that the part of the reduction is delayed to 29. If we did not get that component, it would have started in 26.
Okay. Thank you.
And just one change I want to flag here too is the federal law did include, and I think this is a positive thing, a new home and community-based waiver, and it allows states to do home and community-based waivers for individuals who do not need institutional level of care. And so the effective date of this one, it is further out. It's July 1, 2028, but I think it's a positive development for that group.
And we're still expecting to hear sometime in this calendar year on our waiver that we did submit for presumptive eligibility.
Marissa?
Do you anticipate that New Hampshire will be considering developing a new waiver, or is it too soon to tell?
Too soon to tell.
Okay, thank you.
And then the final piece on the federal legislation we'll flag here is the Rural Health Transformation Program, and it's essentially a grant program for states totaling $50 billion to be used for fiscal years 26 to 2030. And that $50 billion is allocated where 50% is shared equally across the states. And then, so that's about $500 million per state, and then 25 billion. The other half is distributed amongst the states based off of the percent of their rural population that's impacted based on the federal changes. And there's still a lot of information we need from CMS on this point. The legislation does detail at a high level what states can use the monies for, and it requires states to submit an application and a plan before the end of the year, and CMS has to approve the plan and payments out by before the end of the year.
Well, the half a billion is over. No, it's 100 million.
Yeah.
For over each year over 5 years. And the 5 year period I think will be 27 to 32. And we're organizing a process to seek stakeholder input. We'll be having announcements on that. We'll make sure that this committee gets that information. But it's not for uncompensated care. That's a specific thing we've heard, not in the form of written guidance, but from Dr. Oz specifically on more than one occasion. It's really to help adapt to that $3 billion impact by trying to find ways to transform and make our system more adaptable to different funding streams. States then can compete for that other portion. There'll be, New Hampshire's a small state, so we're getting the first tranches, we're getting equal amounts. So a state like California has hundreds of rural hospitals. We have 50, 60. But it's intended for not just hospitals, but the legislation speaks that the health centers, it speaks to federally qualified health centers, basically rural health system.
Yeah, all provider types.
And the money can have, like for example, one of the criteria that you can apply for around is strengthening a network of providers, which can mean that some of the money with a larger institution that's providing support services to a smaller institution. There's a lot to be unpacked here, and it's going to move kind of quickly when it does move. But we're waiting for guidance on this as well.
Thank you. I think someone put in the chat, my understanding is that 50% of the funds are divided equally among the states and the remaining is per capita. Is that accurate?
I think that's what they're saying. Per capita qualifying as rural.
Yeah, so a lot to come on that one. And that application, the decisions have to be made by CMS by statute by the end of the calendar year. So we're believe, don't know for sure at this point, that our application would be due at November 1st or
Right. So we change the channel to some of the more immediate state changes. I know we talked briefly about co-pays. I think it was last month.
So I think we talked a lot already about the earlier one, which is the return to regular eligibility. The premiums for children start at 255% of the federal poverty limit. Just recently, we were able to get some technical assistance on that topic. And what we do know is that children, as you may recall or may not recall, children have 12 months of continuous coverage, irrespective of premiums. And we're working closely with the commissioner and others on hardship criteria. I don't have anything more to say other than that's part of the plan. We're still looking in our early stages, looking at how we're going to bill the premiums. But just I think the most important takeaway today is that once enrolled, the child gets 12 months of continuous
So if I hear you correctly, failure to pay the premium does not result in disenrollment.
During that 12-month period, could at the end of that 12-month period.
Got it.
The other thing just to keep in mind, we cover almost 90,000 or more than 90,000 children. This applies to under 9,000 children, so less than 10% of the enrollment is subject to the premium. We talked earlier about the granted advantage premium. That is a 2027 item, but now we have to work through on a technical basis the conflict between what was passed federally and what was passed in our legislature. So don't have an answer for that, but it's not a 2026 state fiscal year item. So this would be a state fiscal year 27 item.
Can you remind, well, me and maybe others who are curious, the amount of money that the legislature assumed would be generated for the biennium through the premium on these 9,000 kids, and then
less than 9,000. I think it's probably, I think we estimate, sorry, 8,600 children. And in terms of the first year, we assumed a little over $3 million because things they won't hit everybody all at once. And then it'll take us some time to stand up the program. We have to give advance notice. We have to implement everything. The second year, I think we're estimating about 11 million. For the granted advantage population, it's not everybody in granted advantage. It's about 17% of the enrollment, roughly about 10,000 individuals or so that would be subject to the premium. So more than 40,000 people will not. And that's between 100 and 138% of the premium coming out the federal poverty limit. Pharmacy copays. We're working on the legislation call to increase the pharmacy copay from either 1 to 2, which it's been since the early probably early 2010 or earlier, to increase it to $4. We're working through the implementation of that. There's some decisions that we're waiting on relative to how it rolls into play, but we can do this at another meeting. There's a wide number of individuals who are protected from the premium, like people in nursing homes, children, and others. We can share that information. But that policy, we're probably a couple months away from that going into effect. On the pharmacy front, also in HB2 was related to what we call generics first. It was originally under Senate Bill 119. That has required the state to always use a generic over a brand name, even if, and I don't think people realize this, even if the brand name with the rebates the states receive was a lesser cost than the generic. And so we brought that to the attention of the legislature. We did analysis with our actuary. And this is to save the state money. We're assuming in the first year about $1 million, and in the second year a little over $3 million. And I think many people might prefer the brand name.
Are there any other near term topics that folks are hoping to?
So I know you said couple of months from implementation. So is the goal like November 1 for the copays, or
I think when we're able to have, we'll have to have an effective date established. And so once that's locked in, we can share it with MAC. We'll also be sharing any member facing materials. So MCOs will likely need to update their member handbooks. There's going to be updated notice letters on copays. So things that are updating and going in front of members, we can share by email with this group.
Okay, I just was looking for the clarification because my impression from last month was that it was happening much faster. So this is helpful.
We had hoped that it would. There's been a lot going on with the federal stuff that wasn't anticipated when we were planning our timeframe. Yeah. That we've had to pay attention to, like for example, getting the grandfathering in place so we could push out things a couple of years.
I don't question your prioritization at all. I just wanted to make sure that I was tracking. So it's great.
No, I appreciate that, and I appreciate it. I feel, so people know, we feel supported by this committee, and there are some tough things to work through that we're going to do our best to do the best for people as we've done, and I think I'd hold up our efforts of our team against any state in terms of what we're trying to do to keep people covered. Continue to do that, change up our strategies to be more effective where we can. And in terms of high priority people who are eligible covered is the highest priority that we have.
Speaking for myself, it shows. Thank you.
I think there are other things that are out there, but I think that we hit the highlight of the major ones that I think affect the beneficiaries directly. We talked about some of the other bills that were signed into law that, quite honestly, we now have to figure out what we're going to do with those things, like around the dysphoria. There are things in the legislation we have to consult with our medical director and others to figure out how to work through those. But I think the main thing is the timing of most things. We have some runway to plan for them, and it seems like a long time, but we'll meet every month to get there.
Okay. I know we're running a little low on time. Well, maybe we're kind of where we're supposed to be. To get into department updates. Dr. Chang, you are up first for adult dental.
Great. Thank you. Happy news to share. We're able to add a practice that will treat dental patient, young adult with special needs.
Okay.
At the current time for the Medicaid adult dental program, we have 196 provider. And from that group, we have 12 locations to see dental patients with special needs. And we have 17 more surgeons at the current time. Or a surgeon for the Medicaid program, it's one of the group that's lacking, and it's very difficult to recruit. So constantly we're working on that. For the month of August and September, for the dental mobile van, we're going to 10 locations throughout the state. We average about 150-ish patients per month. All from the dental side, if there's any questions.
Okay. Do we have Scott on for DDU update?
Yes, good morning. So DDU is still plugging along. As you can see from the stats for July, we had a total of, at the end of July, we have a total of 40 children that were pending, with one of those over 90 days. We had a total of 265 adults pending
with 18 of those over 90 days. We took in a total of 154 new applications in July, which was actually down from June, which was at 173. So we're slightly down applications for July. 66% of the adults on Medicaid have Medicaid through 66% of adults pending have Medicaid via another avenue, whether it's Granted Advantage or other, and 35% of the children. That's really all I have to report. We're just moving right along. Any questions?
I think Cheryl has a question.
Cheryl?
Yeah, my question has to do with dental. I wanted to back up. We went into it too quickly.
Go for it. Sorry about that.
I don't have anything on the DDU. I wanted to talk about the dental just quickly. There's some major issues with the transportation. The new transportation under WellSense was supposed to be MTM. We all got letters effective 7/1. However, this is the important thing to know. Anyone that uses dental will not be using the MTM transportation through WellSense. They will be using the CTS. If they use the MTM, they're going to get a notice of denial of medical coverage from WellSense. It's not medical coverage that they're getting denied, it's the transportation. But the letter that comes out from WellSense says a notice of denial of medical coverage. Extremely confusing to clients. What they need to do is use the CTS system for dental, for transportation, not only for their transportation, but for their reimbursement. It has to go through CTS. So I want you to know there's a major flaw there. I believe that Jenna and I have pushed this forward to WellSense. However, you need to know it because there's some major issues here. Clients are going to be so confused.
Thank you for surfacing that, Cheryl. Thank you.
FYI,
Yeah,
I have all the documentation here if you need any of it, anybody.
We'd like to see what you're seeing for documentation, but
I would
just to be
like to
clear,
concur with that.
just to be clear, the dental program is a freestanding program with Delta Dental. They've contracted with CTS to provide transportation. That's not changing. I think what is transition that happened is that WellSense, like New Hampshire Healthy Families, is now going to use MTM for their non-emergency medical transportation. What we're talking about here is non-emergency dental transportation. We appreciate the confusion there. We've seen some transition issues that we've been managing there. So this is new information to me this morning, so appreciate that. We appreciate anything that you have.
I think just a simple, I think it's just a simple letter of explanation. Saying anyone with dental needs to contact CTS. I think something like that going out, statewide to clients would really be helpful. You could probably do it in a half a sheet, or a full sheet of paper. But I think it's really, it's really confusing. And even if you provided an example, I think it's warranted because, I was confused by it. Okay.
Yeah.
And so if I'm confused by it, clients are going to be confused by it. You know what I mean? So it's not a notice of denial of medical coverage. It's a notice of denial of transportation through MTM, and you should be using CTS. That's what the letter should say. Okay.
Yeah.
That's what this thing should say.
Can I be heard by any chance? Hello?
Ellen, is that you?
I must be. Yeah. This is Ellen. Yeah. I would like to concur with I'd like to concur with everything that she said. Is very, very confusing. And WellSense, when contacted about this, had no clear answers and made it even more confusing. So a letter going out is important, but WellSense somehow needs to
be much clearer with everybody about the difference between the two, et cetera, et cetera. But when people tried to contact WellSense about this, they were extremely unhelpful in trying to unravel any of it. So thank you for bringing it up, and thank you for addressing it.
Yeah, thank you. That's really actual insight for us. So we'll take a look at anything you can send over documentation wise, and then talk with WellSense on their processes, because you're right. This is an area where coordination is needed, since for every person in an MCO, their dental is still managed through a different, even if CTS is the broker for both their MCO and dental, it's a separate phone line and sort of portal for getting those services. So thank you for raising that, Cheryl.
Okay, yep.
Joan?
Yes, hello, good morning. My question is for Dr. Chan in the mobile dental program. Are there any plans in the making for how we're going to continue preventive care for those individuals that were
FYI,
seen in the mobile
on the
program?
MCAC call today,
Hey, Rich, you gotta mute yourself.
just now.
Rich, mute yourself.
And edit it. Okay. Joan, thank you for your question. Just quick questions, Dr. Chang. So Dr. Chang, could you take that?
Yes. We are actually meeting next month, try to expand the dental mobile van schedule. Possible looking at adding more provider, adding more days, adding more treatment in that space. And so I will bring it back to the group after that meeting with the different new strategies. But right now, for a lot of different locations of the state, that's just a very valuable service. Transportation, as we know, is an issue for a certain part of the state.
So do I understand you correctly that you are looking at strategies to move somebody who's getting services from the van, which is great, into a dental home, because the van is more of a transient option and we prefer to have people in a dental home? That's how I interpreted Joan's question. So is that sort of what you're referring to as a strategy that the team is looking at?
There's definitely a limitation with the dental van of what currently we offer. Currently, we don't offer any crowns, we don't do any dentures in the dental van. The focus is on prevention, on basic dentistry, and really getting rid of infection and getting patient more pain-free. Then it could be a gateway to transfer those patients into a dental home. So you're definitely correct. We're looking at maybe adding more surgeon to the dental van. Because again, it's a dental service that's kind of in high demand. Sure. It's lacking.
Yeah.
So we're looking at that strategy as well.
Yeah, I think this is less about the van's capabilities, but more about, okay, you've had a service at the van, now what? How do we make sure that you continue to engage in dental service that doesn't rely on the van? You know, it's kind of like the ED conundrum, right? Like, okay, you appeared in the ED.
More like urgent care.
Yeah, exactly. But you want your follow-ups to be in, you know, with your regular dentist, but we gotta get them a regular dentist.
Yeah.
Joan, I don't mean to speak for you, but that's.
Yeah, and I'm also thinking about, is there a way to also include data on assessment of those particular individuals' choices and abilities for transportation, and what kind of dental home, you know, or preventive care to move them past, you know, the pain-free and the stabilization that you do. What is it that they need? So a needs assessment, I guess, so that we're not providing things that can't, you know, aren't effective. That's my point.
And so far, the feedback from the member that received dental treatment from the dental van are really a lot of positive. So people really like that, and they don't have to drive 1 or 2 hours to get to a dentist.
I can get weekend appointments, which tell me where else in the state you can get weekend appointments.
Right, right. Yeah. that's great.
So I just wanna do a time check. We're at 5 till
Thank you.
12. We've got, I don't know, a number more
Yeah.
bullets.
8:05 people, we have, we
Yeah, we got
met
a
this
couple minutes
morning
on
and we
dental.
really need to.
Maybe
Okay.
we
For
could
the
just close
8:05
that out.
subcommittee.
Yeah.
Okay. Are there any,
I don't need.
are there any other of the department update bullets that have something significant to report? Because again, we don't meet next month, and then we'll get to the 8:05 rule.
And should we ask them if they have questions to put it in the chat?
Yeah, so Lisa Brett, we have one really great positive update, which is that the department was successfully awarded a grant for our implementation of community reentry, which we're very excited about. Thank you. So we'll share more details on that. I did just, if we have the time, just quickly close out Dr. Cicero's question and Tracy on the dental, and then I think everything else in the department we can share as a written update and then go to the subcommittee. Does that work? So, Dr. Cicero, did you have a question?
Oh, not a question. Just I've been working on the van since its inception, and a lot of times they do have a hygienist provided to keep that preventative piece going. And the biggest issue to transition people from being on the van to a permanent dental home is just provider acceptance rate. I work a lot in trying to get providers to accept Medicaid, and that is the biggest barrier to entry. And the van is filling the role of like those in the areas that don't have that dental thing available. So I hear where I was just listening to where Joan was saying, where it's like providing things that aren't necessarily effective. I'd say I hear where you're coming from, but I think that what these people are getting in the availability that they can get it is definitely a huge net positive from where it was pre-2022.
100%. And then Tracy, is there anything time sensitive you wanted to share? Otherwise we'll keep moving.
I just wanted to add to Dr. Cicero's point that we are hosting events quarterly in most communities, and in Nashua and Manchester, we're actually hosting them far more often. And the reason why we're doing this is because we know that there are a lack of brick and mortar locations. Hygiene is a focus, and to Dr. Chang's point, we are going to be expanding hygiene services in all communities to make sure that folks are focused on preventive care as well as tackling, those restorative needs. And for some folks, because of the lack of brick and mortar locations, the dental van is their dental home right now, and it is considered a dental home. And those recurring appointments are being made to make sure that they are receiving the care that they need. So let's not look at this as just an urgent care. Let's think of it as a dental home, and that's the model that we've created and are continuing to create.
Okay. In the interest of time, I'm going to move on from dental. And we'll be posting an updated link for the HCBS spending plan on July 25th. CMS approved our Q3 and Q4 spending plans, and those will be posted this week. And I think everything else we can provide an email update. Want to go to 8:05?
Yeah, they met this morning. Kara?
Hi, everybody. This is Kara. The committee has met many times and gone back and forth with the department with edits to the 805. And we met this morning to go over what our final recommendation would be with the language as is. I do want to thank the department for working with us on the changes and edits that were made. At this time, the subcommittee cannot support the language as is written in 3 areas and would not recommend to MAC supporting the 805. I can very briefly say what those 3 areas are, and then you can let me know what questions or how much more you want me to go into it. I know time is really short. The 80504D, this speaks to a concern that agencies had over declining referrals because of safety risks. These are issues where we've had direct threats to case managers or an incident that threatened a case manager, and then the referrals come back around and we need to be able to decline them, but that has been an ongoing issue. The department
suggested using conflict of interest. We don't feel like the current language addresses our direct concern about safety, and also conflict of interest. The definition in the 805 is not consistent with the federal definition. So we are asking for some more specifics and to have the actual concern addressed. The second would be the 80505E4. That's uploading of care plans to the state system. We've gotten conflicting clarification on this from both legal and program administration, and do feel that the way it is currently written insinuates that we would be uploading the complete in every single one of the case management care plans, which would present a huge administrative burden and financial burden at this point. Would really be unfunded mandate that we would have. And then the third, 80510, which speaks to quality assurance. As we're understanding it, the way the rule is written is adding a great deal of steps and information that would be a significant amount of work over what we currently do for the reports to the department. And the department already has authority to review those records at the agency, so we don't feel that we can support that as it's written. I would open it up to any of the other committee members that would like to comment on any of these. Or not. Any questions and next steps on this? I'm happy to, whatever you can let me know as far as where we go from here.
I think
Sarah,
the only thing I want to make sure I add is that with regard to E in the uploading of the care plans, I think that's an easy solution because we literally are getting conflicting information from the administrator and from the person joining us in the subcommittee. So Brian, Brian's just in the middle, so I feel bad for him, but we're asking for clarity in one thing, and he's coming back and saying, no, they don't want to change the language. But then when we talk to the administrator, or at least one of us has, message we're getting back is, oh no, we're not asking you to do that.
Yeah.
So I think that one, I'm only sharing that because I think that's an opportunity that we can resolve that one. But I don't know that we can resolve D or the QI issue in 0.10.
Yeah. No, I agree, Kelly. I think that if this was about case management agencies submitting portions of the care plan to support a request for a change in service, an increase in service, we're doing that now. I don't believe there would be an issue continuing that, but the way it's currently written, that's not how it's understood.
thank you for laying that all out. And sorry to not leave a lot of time. I was just going to say, if you wanted to submit anything in writing to include in full in the minutes, we'd be happy to do that. And,
I'll do that.
Yeah, and I know we have Christina and Brian on, so I was wondering if one of you could speak to kind of next steps with HEE 805. Or Roxanne, I'm not sure if she's on, I can't see.
Yes, I
Hi.
think Brian, there he is, okay.
Sorry, I just need to find my unmute button. So we will be working on further revising the A05 based on your feedback to try and clarify some points. I don't know if we're going to be able to reach an area where it can be, the subcommittee will feel like it satisfactorily meets their needs. But we will be sending an update to the subcommittee on how we intend to move forward.
Okay. And I'll put the feedback that we have, I will articulate that better than the few minutes that I had, and put that in writing for the committee and get that out to everybody.
And Brian, when can the committee expect that communication?
I think within the next 2 weeks.
2 weeks?
Yes.
All right, thank you
Thank
both
you.
for sharing the feedback and the updates on where it goes from here.
All right. Anything else before we wrap for the day? Okay, can I get a motion, please?
So moved. Motion to adjourn.
Can I have a second?
This is Kara, second.
Thank you. All in favor?
Aye.
Any opposed? All right, thanks, everybody.
Thank you.
See you soon.
Have a great day, everyone.
Bye.
Before you guys sign off, I was just wondering, is it possible I could get, you guys mentioned like the new bylaws and stuff. I was wondering if I could get a copy of it.
It's posted on the website,
Can you send
Oh, perfect.
but
All right,
I
thank you.
could email that to you as well.
All right, that's fine. Yeah, I appreciate that. Have a good
Yeah,
day.
Thank you.
Yeah, thanks for joining. Whew, thank you.
He works in a practices law.
It's so hot in here all the time.